Okay, so why don't we move on to the topic of the talar dome injuries, which, as you all know already, are quite common. Here we can see a subchondral cyst on the medial aspect of the talar dome on this tomogram, which most of you have never seen before. And here's an old CT, which kind of shows the subchondral cyst there. So looking at talar dome injuries, there are a number of classification systems. Probably the most common one is the Burnt and Hardy classification. Stage 1, you have a subchondral bone and the cartilage look okay. Stage 2, you have a partially detached articular cartilage fragment or bone fragment. Stage 3, you have a detached fragment, but it stays in situ. And stage 4, it dislodges. So here we can see you can get a bone injury here. Quite commonly, now we see these nicely with MR. We see subchondral bone edema, and you can see this on either the medial or lateral side. We know that these are subchondral trabecular fractures. And depending upon the nature of the injury, the actual subchondral bone itself can not be depressed, and the cartilage overlying it can still be intact, because remember, we've talked about this over and over again, the trabecular bone is very rigid. Impaction can cause it to fracture, whereas the overlying articular cartilage is much more malleable and may not be injured. And then type 2, you'll have a tear of the articular cartilage and the bone, but it's in place. 3, it's in place but not intact, and then stage 4, it's displaced. So that's Burnt-Hardy classification. There are other classifications. This is a Mintz classification, which is an arthroscopic classification. We have talar dome injuries at 0s where the overlying cartilage all looks normal. Stage 1, you have intact articular cartilage, but it's ballotable, and on an MR examination, the signal may be abnormal with edema within the articular cartilage. Stage 2, you get fibrillation arthroscopically, but you can't see the bone. 3, you actually can see the bone, which becomes exposed. 4, you have a loose, undisplaced underlying bone fragment. And 5, you have a displaced bone fragment. So I prefer just to describe the findings with these kind of in mind. And it gets a little confusing saying what stage it is if you don't know what classification people are using. There's an MR classification from Griffith et al., which is a little bit more discrete, talking about different types of delamination of the articular cartilage. But again, I don't know anyone who clinically uses this classification. It's, I think, more for research. But the kind of things you can look for really, again, are the in situ fragment, displaced fragment, and then the degree of bony impaction, subchondral bone edema, and actual tears of the articular cartilage. So those are more the acute lesions. This is one of the first MR scans we did on someone with an acute injury of the ankle. These are T1 weighted images. See the loss of signal intensity, the fat signal within the talus right after the injury. This we now know is from bone edema. We did not have fat suppressed images in those days. Follow up a month later, we can see we can get most of the bone signal back, but we have some irregularity of the bone. And so this ended up being what we'd call a stage 1 injury to the bone. Here's a little bit later. This is a low field scanner. And here we can see some irregularity of the subchondral bone on T1 weighted images. Here you can see a tear of the articular cartilage with a fracture extending into the bone, but the fragment is still looks like it's stable and intact in position here. This would be a Burnt-Hardy stage 2. And then here's another example of coronal plane T1 weighted images where we see the injury to the bone here, an in situ fragment. which is a stage 3. This was in a Major League Baseball player. And here's another injury in a Major League Baseball, sliding into second base, twisted the ankle. And here we can see an impacted fragment with a tear through the articular cartilage. And there's in situ but unstable bone fragment. And you always have to look at the tibial plafond as well to look at kissing injuries involving the tibial plafond. Okay. And then here we can see a little bit of an irregularity of the subchondral bone here on the lateral side. On the axial images, we can see a defect in the bone in this location. And this ended up being a defect here with the overlying articular cartilage torn. And this was a stage 4 at arthroscopy. Okay. Robert, what do you think of this case?
Let's see. Here, there's a lot of subchondral cystic change and irregularity of the overlying cartilage in that lateral talar dome.
Right.
I think this would be stage 4.
Okay. Then we can see edema here also, more acute edema deep to it, which we can see on the STIR images, and not so well on the T1 weighted images. And if we look carefully around the joint, we can find a displaced fragment here. So this was a stage 4 with displacement.
Okay, so here in the medial talar dome, I see subchondral cystic change. I see the cartilage very well, but
yeah, we don't see the cartilage very well. This is cystic changes. This has a different kind of appearance to the other ones we saw. This is really more of a chronic lesion. Those other classifications are primarily for acute lesions. So, and this is all grade 4 chondromalacia. There's no articular cartilage on top of the talar dome in this location. So this is just chronic degenerative disease like we see with subchondral cystic changes, and really not part of the acute classification system.
all right,
It's a
so
low field scanner.
looks like severe cartilage loss in joint space, narrowing tibio-talar joint, extensive subchondral cyst. It looks like bone-on-bone articulation.
Right. And then here you notice there's a lot of remodeling.
Yeah.
The tibial plafond should go straight across here. Here it's being worn down, it's remodeled. Here we can see that there's a direct bone-on-bone articulation between the lateral malleolus and the lateral aspect of the talus. There's rotation of the talus, so you have lateral bony impingement here as well. But we can see this is very chronic because you have remodeling of the bone here.
Yeah.
And in the sagittal plane, we can see all the degenerative disease and bone-on-bone articulation. Another low field scanner. Robert, what do you think of this case?
Here looks like there's been a tibio-talar joint replacement there.
Yeah.
Prosthesis. Hardwood looks like I think it's well aligned, but I haven't seen a whole lot of these.
Okay. So here, this is on 9/19/08, and this is on 4/3/09. And what you notice, the difference here is that the joint space has narrowed over this time period. So the prostheses now are much better than they were back in 2008 and 2009. So back in those days, what we looked for frequently was whether you got wearing of the spacer here, the polyethylene. And this is an example of where you're wearing the polyethylene over time. The newer prostheses, this doesn't happen to as often, but this was something we were looking for previously. And you can see the patient had a prior fracture, which led to the joint replacement. And here we can see on the sagittal plane how it narrowed going from 2008 to 2009. Okay. John,
Yes?
were you going to say something?
No?
No, sorry.
Okay, so here at looking at the tibio-talar joint, looks like there's bone fusion anteriorly. And yeah, posteriorly, I don't see normal cartilage. Looks like there's
Right.
bone-on-bone contact there.
So this is a bone fusion. John, this is fused in flexion. Is that commonly done with women?
Um, I don't think so.
Yeah,
Usually, it doesn't fuse. Usually it becomes loose and wobbly. So this is kind of a rare situation.
okay, thank you.
I mean, you're a radiologist, so you've probably seen more of these than I have.
Right.
Uh,
Yeah, most of them I see them fused in a more neutral position rather than in flexion. I thought maybe some women might like it in that position if they like high heel shoes or something, but to me that seems very awkward.
All right, so looks like there's complete bone fusion between the talus and the tibia and some susceptibility artifact more proximally.
And it looks like we have a little bit of malalignment here between the distal tibia and the
this is a tibio-talar fusion. I think somebody did surgery on this patient and
right.
they didn't put it in quite the right position.
And then we also have stress changes to that navicular bone as well.
Right. So
The tibia is too far posterior and the foot is too far in,
yeah, which is
distally.
probably increasing the stresses on the navicular here. And so this patient was symptomatic because of a trabecular stress injury of the navicular bone. Good.
Then what will wind up is another fusion, which makes it a pan-talar fusion, triple arthrodesis,
Okay.
which is talonavicular and then talocalcaneal and cuboid. That's a triple arthrodesis, but this is going to wind up in a pan-talar, which means the tibia and talus also on top of the triple. The triple arthrodesis is one of the most common procedures done in this area from trauma.
Okay. Thank you. Okay, Robert.
Okay. Here it looks like there's a prominent steata process with edema and I think a fracture.
Yeah. So that's a fracture of the steata process. Okay. What do you think?
Yeah, so looking the anterior calcaneus, I think maybe it's at its articulation with the cuboid. Looks like there's maybe edema. Looks like a fracture.
Yeah. And then if we go to the sagittal images, the anatomy is a little bit more clear.
Yes. Yeah, so the anterior process
Right.
fractured. Yeah.
It's an anterior process fracture, which is a fairly common fracture.
All right, here we also have a fracture traversing the anterior process of the calcaneus with edema.
Yeah. Good. Good. Okay, Robert.
All right. Here we have this one looks like more of an ostrigonum, and then there's pretty extensive degenerative change of that subtalar joint posteriorly. Yeah.
Right in through here, and probably some chronic granulation tissue here in the dorsal aspect of the talus, which is probably has decreased height due to compression fracture. And yeah.
There's quite a bit of injury here and others. Well, degenerative disease and the whole hind foot.
Right. Absolutely.
This is not a good place to get fractured like
Right.
this.
All right, so I'm looking here at the medial calcaneus. I think we're at in the region of that medial facet of the subtalar joint. Yeah, looks, it's just this irregularity that looks like a fibrous coalition or, yeah.
Right. Yeah, this was a fibrous coalition. You know, you might also put in the differential degenerative joint disease, but this kind of speculation is very characteristic of fibrous coalition and not so much. Usually, degenerative disease is smoother with less sharp margins, and this is the kind of characteristic appearance you see with a fibrous coalition.
All right, so there's a bone infarct in the distal tibia.
Okay, good. On a low field scanner. So, patient came in with ankle pain. Kind of what's your differential if you just see an infarct like this?
Um, some sort of vaso-occlusive disease.
Yeah, it was good. But the characteristic ones that I've seen most commonly that have come in as surprises are sickle cell disease, which shouldn't be that big of a surprise, and lupus. And this was a patient who has lupus erythematosus and developed ankle pain due to a bone infarct. And bone infarcts are pretty common with some groups of lupus patients.
Cortisone.
Yeah, could be if they're on a lot of cortisone, right? Robert?
Yeah, this one looks like another case of bone infarct in that distal tibia and probably the talus as well.
Right. And I don't remember the diagnosis here. It was probably sickle cell disease, but I'm not sure. Okay.
Right, so here in the subtalar joint, it looks like looks like part of a screw, but I'm not quite sure. I mean, certainly a surgical device.
And you can see there's this fracture of the talar dome
Oh yeah,
as
yep.
well. But what is this? And this was called a subtalar fusion by the podiatrist. John, do you want to talk to us about subtalar fusions?
This is a piece of metal that contains bone, either the patient's own autograft or somebody else's allograft that they put in a container, and it has holes in it, and it hasn't been effective in this joint. It's you can always put a graft in there, which works better, but this area is not very good in fusing just by using one kind of a device like this. You have to remove the cartilage, etc., and then do just an ordinary fusion like you would other bones and put screws across. The talus obviously has got a problem, and that will eventually either need a I don't know how old the patient is, but you might try total joint replacement or fusion.
Okay.
But that's not going to fuse the talocalcaneal joint. It's obviously not going to fuse. At least I don't see any fusion. Do you, John?
No, not at this point. I don't. Right.
No, that's what we worked on this design at Orthopedic Hospital for USC, but even went to space with it. but it hasn't turned out to be that good. Like in the back, it probably works a little better.
Okay.
So that osteochondral fragment has been anchored down there. Is that what those lucencies are?
I don't think this has been operated on.
Okay.
No, I don't think so either.
I'm pointing this primarily for the subtalar effusion,
Okay.
which
Yeah, that
I've seen
could
a
have
couple of
occurred
these.
on another day without fractures. The talus.
Yeah.
I don't think they would have left it alone and just fused. But then again, podiatrists do things, and I don't know the history of this.
Right. I don't remember all the detailed history either, but I just wanted to point this out as one form of subtalar fusion.
All right. So looks like posterior calcaneal screw is like a calcaneal talar fusion.
Yeah, so what happened here is they put this in to fuse it. The patient developed pain, so they had to remove the hardware, and then they were left in a situation where they had this large defect from the hardware. You can see some bone edema here, but without clear-cut bony fusion
Yeah.
involving the subtalar joint here, and that was a failed fusion.
Now, these attempts to fuse the subtalar joint with this kind of a screw and going in from the tip of the heel is not a good idea. Much better ways to fuse this joint than what we see so far.
Thanks. Robert.
All right. Let's see. Well, it looks like the navicular bone's not appropriately articulating with the cuneiform there. So is this dislocation?
Yeah, so this is an old dislocation, and you can see a lot of instability, and the navicular is really markedly medially displaced here and rotated.
It's about as flat a foot as you're going to get. It almost looks like a congenital vertical talus.
Right, right. This was acquired, and I don't remember the details of this. I think the patient just didn't present for medical care until it was really late in the game.
It's hard to tell, John, actually, whether this could have been a vertical talus problem because that's what it causes, but we don't see any signs of fractures anywhere. But this is an old situation, obviously.
Right, right.
Usually you have to treat these at birth.
Right. If it was congenital, right.
You treat them pretty much like a club foot.
Mm-hmm.
Okay, so here, yeah, the
patient came in with chronic ankle pain.
yeah, I mean the talus, I mean, is gone really. The tibia's articulating with the calcaneus.
Yeah, and this was post-operative. So they went in and just removed the body of the talus.
Okay.
John, do you want to comment about this?
That's been a procedure that was used, and if the talus, well, I don't know if you're going to get on talar fractures. I'm sure you will, but it's not unusual to get avascular necrosis of the talus with fractures of the talus. So, but I don't know what they did here. It's possible that the talus was dislocated, and I know of a case that the talus was dislocated, and the orthopedic surgeon tried to put it back in place, and the talus fell on the floor. And so
Okay.
washed it off in surgical soap, and they put it back in.
That's when I decided to stop doing surgery, John.
Pardon me?
I said that's when I decided to stop doing surgery. Yeah, right. Okay. Let's see, who's next? Is it Robert?
I think it's me.
You? Okay.
Sialastic implant.
But this obviously needs a fusion on the
Yeah, so we're looking at the
more than one bone.
first MTP joint.
Yeah.
Has a hardware that looks disarticulated.
Well, it's fractured.
Yeah.
This is the stem. That's the articulation for the metatarsal bone, and then here's the articulation for the proximal phalanx.
Yeah.
And this is
A lot of resorption, right?
This one's fractured, and this one's just dislodged from the bony from the
Yeah.
bone.
A lot of resorption around the hardware and a fluid collection of the plantar
big fluid
aspect.
collection. So I think John was talking to us about these kind of implants before, and
Well, we used to do a lot of these,
Silicone?
but
yeah, and
they fell apart, unfortunately.
and that's what it looks like.
It's a Clayton procedure, they're called Clayton procedure. What you do is you remove the joints of all the bones. That's usually in rheumatoid arthritis. And it usually gets rid of all pain, and the patient becomes ambulatory, and it works extremely well. So removing all the joints of the foot and then wearing comfortable shoes that are pre-made works out pretty well for the rheumatoids. But putting in Celastic, as we have talked about, is not something that we want to do in orthopedic surgery. Breasts, that's a different story.
Okay, great. Okay, Robert.
All right, so we have a 72-year-old female with foot pain. Looks like there's a lot of edema in the metatarsals there with some irregularity and subchondral cystic change. And a lot of soft tissue edema there. Scarring.
Some separation here.
Mm-hmm.
Okay, there are the sagittals.
Yeah, it looks like a lot more of that degenerative change of the TMT joints there, and
Yeah, a lot of muscle atrophy here.
Mm-hmm.
Hmm.
Yeah, some more of the same. So I'd be concerned about like a Charcot arthropathy.
Yeah, this is diabetic patient, and this is a kind of classic discombobulated foot, which is characteristic of Charcot disease.
It's difficult to treat.
Yeah, and that
This is where a good shoemaker comes into play.
And generally you're asked to differentiate, is this just straight Charcot disease or is it osteomyelitis? So the couple things to look for, you look for abscesses within the soft tissues, which you should not see with Charcot disease, but you can obviously with infection. Typically, if you have osteomyelitis, it's relatively localized, not always, and you get an acute bone marrow edema pattern that looks more like an infection. With Charcot disease, you tend to get a more generalized pattern like we're seeing here, and you have these characteristic subchondral cystic changes, which you typically don't see in infection. With these kind of margins here, with infection kind of obliterates everything, and the edges of the joints are not so well discerned because they're all eroded off, and the edges of the bone are eroded. Whereas with Charcot disease, you get these sharper margins, sometimes kind of pointed areas, not like gout, but kind of that way, and these subchondrocystic changes, and the edema pattern. When you see different ones, this is much more a degenerative type edema pattern. On the T1 weighted images, we can see a nice dark structure, which is relatively well demarcated, and here with infection, you don't have these kind of sharp margins. It's just all just obliterated. A lot of the anatomy is obliterated into more of a edema pattern with indistinct edges, whereas here we can see distinct edges, and this is much more characteristic of Charcot disease.
And you probably see more swelling and infection and
Absolutely.
a sick patient.
Yeah, and you'd see generally a lot more diffused soft tissue edema, whereas with Charcot disease, you can see the soft tissue edema is relatively sharply delineated, and you don't see this edema, really massive edema going involving all of the soft tissues. So,
What's kind of interesting here is that metatarsal tarsal arch is kind of involved in entire arch.
yeah, all the way across here,
Not one or two, but the whole shebang.
which is more common in Charcot disease than
Yeah.
osteomyelitis,
Yeah,
but it just depends on the
osteomyelitis
extent of
usually
the infection.
affects one or two, but
Yeah.
by then treatment is started.
Mhm. Patient with diabetes with chronic pain.
It's chronic pain. Right, so there's bone edema surrounding that TMT joint with degenerative change, edema in the plantar muscles. I mean, it seems like Charcot arthropathy. I don't know if
Yeah.
it's osteo here,
Again,
but
yeah, this subchondral cyst with relatively sharp margins. The edema pattern, we will show examples of osteomyelitis in the next lecture when we start talking about inflammatory disease. You can get edema in the soft tissues with Charcot, but you shouldn't get abscesses. And then, so this is I don't know. I guess I got this from this particular paper where they were trying to differentiate these, and this is kind of our condition here. I don't know. Forget it.
All right, so we have a hallux valgus deformity, and
Where do you think that came from?
I don't know. I feel like this would be congenital.
No, I would say that this from shoes. This is probably a female. And you have a bunion and you have a hallux valgus.
Okay.
And we have severe first TMT joint degeneration, second TMT, and third TMT as well.
Yeah. And again, we have this kind of cystic change here, a lot of muscle atrophy, characteristic of chronic Charcot disease.
The only thing is we don't know how long this patient had it. But I would bet it was a female.
Yeah. Robert.
All right, so we have an 80-year-old with chronic foot pain. This looks like a PET scan. There's a lot of increased tracer kind of at the TMT joints. That's just, I would suspect degenerative disease. But...
Okay. Yeah, this was a patient who had Charcot disease, and that's just what a PET scan looks like in someone with Charcot disease. Not that you would use a PET scan for the diagnosis.
okay, 55-year-old with foot pain. Yeah, again, looks like degeneration and fragmentation of the second and third metatarsals. Yeah, dislocation of the TMT joints. Plantar subluxation of the cuneiform. I mean, yeah, is this degenerate? Well, could this be an old fracture, displaced fracture?
This is an old displaced fracture.
Mhm.
And the
Well,
metatarsals
it's
were partially
dislocation also
affected by the
because
tendon pulling.
the bones are displaced.
Right. All right. Well, why don't we stop here today and we'll start inflammatory disease the next lecture. Okay.
Thank you.
Thanks.
Well, have a good afternoon, everybody.
Thanks, John.
Welcome back.
Thank you.